All right. So my task is going to talk about distal radius in geriatrics. I'm going to focus more on tips and tricks because it's, I guess, controversial. We have talks, bunch of talks. I could spend probably like half a day talking about do you operate, do you not operate. But by raise of hands, after, let's say, 67-year-old, operation or no operation, would you operate on a 67-year-old distal radius? Can you raise your hand? Okay. Where's a non-op? So there are people out there, well, there's a lot of people out there who say after age 65, no one gets an operation. And I think it's a little bit more nuanced. The thing is that a lot of the data actually kind of shows that like your functional deformity does not equal to outcomes. And so there is data supporting non-operative treatment. But there's also data showing that if you have a lot of gross deformity, like radial shortening greater than 6 millimeters, so forth, then actually it does impair function. So there is data supporting. But then it's all over the place. And so instead of spending time discussing that, I'm going to assume that we've decided to operate on some of these patients. I'll show you some of the tricks to get out of trouble. All right, so this is a 45-year-old. I got the memo. This is geriatrics, right? But I'm using a 45-year-old as an example, and I explain to you why. And by the way, this age 65 for geriatrics, do you guys know why we use 65? Is basically, historically, it's a number that was picked for Social Security distribution. And so 65, after 65, you're geriatric. And then also at 65 is, with some exceptions, I'm not sure if it's 62 now, but then like Medicare would kick in. And so that's kind of where the number came from. But for me, geriatric, there could be 45-year-olds who are like, for example, like dialysis, or they had a stroke. That for me is a geriatric bone, which is like osteoporotic bone. Like for Arnold Schwarzenegger, I use him as an example. He's 77. I would not, and he's very, very active. I would treat him like he was a 50-year-old, okay, depending on functional status. So this patient, 45-year-old, had a motorcycle accident, very high energy injury. And if you look at the CT scan, this looks really bad, right? It's lots of pieces, very comminuted. We got a 3D recon, and they converted that into academic interest into 3D printing. I like doing this because if I have access to this, I like to give the patient a copy of their 3D print so they could just have it as a souvenir. But it also helps us look at it. The residents take a look at it and sort of try to match the CT scans without the 3D recons, and then also the x-rays, and try to see if you could actually get to this pattern just by looking at the x-rays. But good thing about this I wouldn't say good thing, but then like Dr. Schroeder said, that a lot of times these distal radius fractures, they actually have a pretty predictable pattern of disruption, and those are the components of the distal radius. And this was fixed. This is younger patients. I fixed this with lots of plates, right? We're orthopods. We heal with steel. That's the saying. Now, let's go back here, okay? Now, that was a high-energy 45-year-old, right? And we're talking about geriatrics. This is a 65-year-old woman. She fell from standing, okay? This is not a car accident. She fell from standing. And look at, this is the CT scan. She kind of has the same pattern as a high-energy injury. I think that's one of the big differences between a younger patient and an older patient, or a patient who has low bone mineral density, is that it takes lower energy to become a high-energy injury. But the good news is that it also follows this specific type of, it sort of tends to follow this pattern on average. And so the question is, should I spend 3.5 hours to reconstruct it and put a bunch of metal on this, right? One of the advantages, I think, if you're a 20-year-old, I'm going to spend 3.5 hours and try to reconstruct your joint. I'm going to open your joint. I'm going to do 3 approaches. As you get older, I think the articular surface doesn't need to be like 100% perfect. You just kind of have to get the geometry. And so for me, I would probably not do a fragment-specific fixation for this. And so my focus on this talk will be how to go from this fracture to that, okay? And this took me like 75 minutes. And I think, so this is her outcome of 1 year. It kind of holds. So this second case will kind of illustrate the steps that I take. And it's actually not that hard, and it'll make your life a lot easier, okay? One thing you have to know about patients who have really soft bone, you guys are all orthopods, you guys have fixed distal radiuses too, right? is that especially if you have like a volar cortex, you have to be really, 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 really careful when you jack it open to basically disimpact the fracture, because it'll break. And so if it breaks, then your surgery becomes much longer. So you want to be really careful. Be really, really careful about your exposure. So once again, this 6 to 7-year-old, this looks like a really high energy injury. As you can see here, there's a small lunate facet fragment. There's a central depressed piece. The axial CT scan just doesn't look great. You know, that's the distal radius. But then one thing I look for in a CT scan is I want to make sure that there's no flipped pieces, okay? Because if there's a flipped piece, then you actually have to go after that. Either you go through the fracture and you flip it and you put it in through the same volar approach. In a younger patient, I'll probably go dorsal and then key it in dorsally. And so this is a just kind of like a traction view in surgery before I started. One thing to note here is that there's a lot of comminution, right? There's bone. I don't know where this bone, I guess the bone gets compacted, right? It's a closed injury, but then the bone disappears. And so there's bone loss here. And then the articular surface is really, really comminuted, right? There's depression of this dorsal piece. There's a big gap. And so, you know, when you look at the situation, you're like, oh my God, this looks really hard, right? Do I use K-wires? What do I do? And what I found, a very simple technique to sort of get out of this trouble is basically I use the back of a key elevator. And I like to use the back of the key elevator because it's not really sharp. And so you use that, and then you book open the volar cortex or the radial stylet, whatever you have to do, and you just slowly just tamp up your articular surface, okay? And sometimes I over tamp. I go all the way, I go even further than what my articular surface is, and I put cancellous bone chips, and I crush it, right? I put cancellous bone chips. And then I could, even if though I over tamp it, I could use the carpus to kind of reduce back down. It's gonna collapse. And I do this not for bony healing purposes. I do it because it just makes sense, right? You have bone loss. My residents say, oh, this is like a plateau. I'm like, no, a plateau is like a distal radius, right? So what you do is you actually basically bring up the articular surface. If you don't put anything behind it, it's gonna collapse. So you have to put K-wires, and it becomes a mess, right? So if you slowly disimpact, put bone graft, and then you may end up with something like this, right? And like I said, this is, it looks pretty hard initially, but it's actually not that hard once you start doing this technique. Then in that segment, that's basically like probably around 5 cc's of bone graft, okay? Another thing I mentioned is that the lunate facet was really small. So in this fracture, I used a hook plate because my system had a hook plate. Dr. Schroeder mentioned the terrible consequences of having a volar escape, and especially in patients with low bone mineral density, even though you feel like you might have captured it, like the metaphyseal portion, the way I like to think about it is by week 2, it kind of softens the metaphyseal portion. It gets skipped over the plate. And if I'm thinking about it, I'm going to probably do something about it. And there's 2 techniques you could use, which I will discuss as we move further. So now they have this 74-year-old female retired ICU nurse. And so looking at this fracture, 74, retired, she's still pretty active. Who would offer operative intervention for this? Okay? Who would offer non-operative management? Yeah, I mean, you can, right? So I had this conversation with her. I was like, look, your, well, number one is kind of like it's like a Barton's type of fractures, but it's not like completely off. She probably has a gap here. Her carpus is a little bit translated, so she probably has a gap and she's sort of coming anteriorly, but then she's also 74. And I talked about all the, my interpretation of the literature, and I said it's reasonable to treat it non-op, but then she's like, I want surgery. And she's an ICU nurse, so I'm not gonna argue with the ICU nurse. And so we get a CT scan. If you look at the CT scan, there is a gap, there is sort of volar translation, but the DREJ is actually not that bad. the data for gap versus step off is not that clear. So I know with step off leads to arthritis, right? But then with gap, there's not that strong of evidence as to what happens with that. But then given these findings, I mean, I'm not treating the x-rays. We discussed it again. She's like, I want an operation, right? So we said, fine. There's actually, just going back a little bit more, there's a study from Dr. Kevin Chung and also Dr. Calfee, who looked at what elderly, I guess, geriatric patients prefer, and there's a very strong preference for shared decision-making in that population too. So now, for her, what I did is basically did the same technique, opened up the volar piece, and then this dorsal piece was sort of impacted. So you take the back of your key elevator, disimpact, put allograft, and then close the door. And then this is the result you get. Once again, allograft. It works really, really, really well, okay? Now, for elderly patients with osteoporotic bone, you can dorsal span. It's been well described. The problem I have with dorsal spanning or X-fix is that sometimes you just throw it at anything that you feel like it's really comminuted, right? I do have an algorithm. Oh. Sorry, I don't have the slide. So basically, this is what I do for dorsal spanning or X-fix. So after you reduce the fracture, if you get a CT scan and it looks acceptable, then for me, it's either a dorsal span or an X-fix. I usually put a dorsal span. But if you have to go after the fracture because it's really displaced, I don't think dorsal spanning is an indication until you actually fix whatever you need to fix. So this is a 75-year-old woman. She fell and has this distal radius fracture, got plated. This is a case I did when I was a resident. I felt pretty good about it. And so I felt like I got restored the anatomy. But what happens is that at 2 weeks post-op, even in her splint, she had actually jumped a cast, right, the splint. She had jumped a plate, even in the splint. And so this is the concept of the volar escape. And it's really, really, really hard to fix. And this was fixed with this volar rim plate, which we had to take out. So in patients who have osteoporotic bone, small lunifacets, and the question is how big is small? There's a study that came out looking at what size you should consider supplementing it. The answer for that study was, I think it was 21 millimeters, but I don't even look at that size for elderly patients. If I fix it and I feel like there's some movement, I either put a hook plate or I put a dorsal spanning plate to fix it. Now, in summary, for osteoporotic geriatric patients, ground level falls can be considered high energy sometimes, depending on the fracture pattern. This has really changed my practice, using this as a reduction tool, okay? And then I always have either a system that has a hook plate, or I usually have a dorsal spanning plate available for all of my intra-articular distal radius fractures for geriatric patients. Thank you. So usually you put it to the, usually you have like a triangle. It's usually the fractures that tend to fall forward are the ones that have like a kind of like a Barton's component, like a volar Barton's. The ones that are dorsally tilted usually don't fall forward, even though you have a lunate fracture. So they looked at a CT scan study, and then they looked at like 21 millimeters was like the cutoff. So if you have like 22, then you might be okay. But basically the way I think about it is when I put a plate, and that plate was a little bit proximal, right? When I put a plate, and even if I catch a bit of the triangle, in my brain, I say this little triangle is gonna get soft by week 2, and it's gonna jump it. If I think about it, if I'm worried about it, I do something about it, which is either a hook plate, which will add another 10 minutes, but you have to have the right system. Not every system has that. Or I put a dorsal spanning plate.
So that brings me to my second question. So the dorsal spanning plate, you showed examples of it being on the 3rd metacarpal, and you showed the last example on the 2nd metacarpal. Which one do you go for?
Yeah, so usually primarily I go to the 2nd. It's a lot easier to slide down. The third one, I usually put either I have like a big open, incision, or someone put an X-fix in the second. So I just go to the third. Yeah.
A lot of companies now have plates that have a hook over that lunate facet, which I found very useful, and you may have to come back and take it out, but at least it captures that little piece for you. And it's I have found those are pretty good in eliminating that complication, which has also happened to me back in the day. So,
Yeah.
great. Okay. Thanks, Nick.